all
welcome you
and
all. So let me
okay,
just give the So good evening,
okay.
good evening, everyone. So I welcome you all for today's webinar on Cancer Treatment Updates 2025. With immense pleasure, I would like to invite Dr. Manish Sharma, a consultant head of unit Medical Oncology, Positron Super Speciality and Cancer Hospital, Rohtak. So the stage is all yours.
Thank you so much. Uh, Good evening, all, and thank you so much for joining this evening. And we will be today discussing about lung cancer, most importantly, focusing on the EGFR mutant lung cancer, and then we will be diving into the genomics of the solid tumor. So the first speaker today with us is Dr. Varun Goyal. He is a senior consultant medical oncology in Rajiv Gandhi Cancer Institute. So sir will be speaking on advanced EGFR and NSCLC and the evidence behind the evidence-based treatment for the targeted therapies. Good evening, sir.
Good evening, Manish. How are you?
I'm good, sir.
Good
You
to
can
know.
start, sir.
Yes. So, first of all, thank you, organizer, for this opportunity. And as already Manish have like introduced that I'm going to present what is the current management and what should be the standard of care treatment with some real world data for the advanced EGFR mutation positive NSCLC patients. What should whether we should go for third line um, osimertinib upfront, or whether is there any role of sequencing from first or second generation to third generation. So next slide, please. So to start any presentation, first we should know that what is the burden of disease and what is the unmet need. So we all know that lung cancer is one of the most common cancer among, or if we talk about all sexes or male. In according to Globocon in 2020, lung cancer is the second most common diagnosed in male and third is in the females. It is number one cause of cancer-related mortality in males and number second in females. So in India, according to Globocon 2020, it is the fourth leading cause of cancer-related death and fourth overall incidence-wise. And out of all different type of histopathology of the lung cancer, NSCLC is the most common type. Although nowadays, just pathology-wise distribution and is not valid, and we have to do genetic profile of every lung cancer patient to see whether to look for any driver mutation in these patients. Next slide. So if we see relative survival rate by the stage at diagnosis, so stage wise, although stage one patient diagnosed in 1% only, around two-thirds of the patient diagnosed in stage four, and survival wise, 5 year survival in stage one is up to 92%, but in stage 4A, 5 year survival is less than 10%, stage 4B, 5 year survival is 0%. So this is a very, disease with associated with dreaded prognosis, and there is still high unmet need, especially for advanced stage, stage 3A onward, because their 5 year survival, even after all the available options, is still less than 30%. Next slide. Next slide. So more than 50% of the patient of stage 4, they have some form of biomarker, either driver mutation or PDL1. So these biomarker may be predictive or prognostic. Predictive biomarker is indicative of therapeutic efficacy because there is an interaction between the biomarker and the therapy on the patient outcome. Prognostic biomarker are the indicative of the patient's survival independent of the treatment received because the biomarker is an indicator for the innate tumor aggressiveness. So more than 50% patients are harboring some form of biomarker, and we should test for those several genetic mutation and PD-L1 status in these patients, and this is according to guidelines, and each and every patient should be checked for this. Most common driver mutation is EGFR, especially in the Asian subpopulation. Other driver mutations are ALK, RAS, HER2, BRAF, PIK3, CA, MET, NRAS, and others. Next slide. And for testing these mutations in the lung cancer, although if we do reflex test like a single test for every gene, although nowadays it is not a like a dictum, and we usually don't do that. But still, in resource constraint scenarios, or maybe very sick patient, if we try to check EGFR ALK at least as soon as possible. So in those patients, EGFR can be tested by PCR, ALK by FISH or ISC, Roche by FISH, and PD-L1 by ISC should be done. But nowadays, standard is we should go for full panel NGS each and every patient. Next slide. Among different EG5 mutations in the lung cancer, we should check in which exon it is, whether it is common mutation or uncommon mutation. Accordingly, we can choose our EG5 TKI. So these mutations may be on exon 18, 19, 20, 21. Most of the time, 20 is with innate intrinsic resistance, but 19 and 21 is the most common one out of all. Next slide. Based on limited number of studies, the prevalence of EGFR mutation appears broadly similar across all these stages. So it is not like that if patient present with early stage or last stage, EGFR mutation status will not change. It will be on the same exon, and maybe there is some emergence of T790 mutation later, but otherwise it is not depending on stage. Next slide. So as I've told you already, different guidelines, including NCC and ESMO and others, recommend that EGFR testing should be done even in the early stage, because nowadays it is recommended to give adjuvant osimertinib in early stage NSCLC after surgery or CTRT. Next slide. So coming to third generation TKI, which is standard of care nowadays, osimertinib, it is irreversible CNS active EGFR TKI, which is selective for both EGFR mutation and EGFR T790 mutation resistance mutation also. Next slide. And landmark study which have established this drug in this landscape of the NSCLC patient treatment, that is FLORA. A randomized double-blind phase 3 study to assess the safety and efficacy of osimertinib if compared with the first or second generation TKI. Especially in this study, they have compared with the first generation TKI in locally advanced and metastatic EGFR mutation positive NSCLC patients. Next slide. So in this, around 500 patients were taken, and like half trial arm is osimertinib 80 milligram per day, with control arm is first generation TKI. And although crossover was allowed, if patient had performed confirmed progression on first generation TKI, or otherwise if T790 mutation was there. So primary endpoint for this study was PFS, second endpoint for objective response rate, duration of response, OS, safety profile. Next slide. So this is the baseline characteristic of these patients. So we can see both the arms are well matched to each other, good randomized study, and representing almost real world setting. Next slide. If we see PFS analysis of these patients, so both the lines are well distant to each other, and this difference is from the very beginning till the very late. There is no crossing over, and at the landmark period of around 1.5 years, still median PFS is way better if osimertinib have been given. Median PFS is 18.9 months versus 10.2 months, and statistically significant, hazard ratio 0.46. So this drug reduced risk of progression or death by 54% if we compare with the first generation TKI. Next slide. And this benefit is in all subgroup. In this forest plot, we can see whatever subgroup analysis we do, every patient or third generation TKI is better. Next slide. Coming to objective response rate, so it is not just PFS or OS benefit, it is ORR benefit also. So obviously, even in high burden disease, no need to start with chemo. These TKI will work and show good response, and show clinically response also. And duration response also twice as long as if we treat with first generation TKI. Next slide. OS analysis 50 final analysis with the 58% maturity, hazard ratio is 0.79, p-value is statistically significant. OS is 38.6 months with osimertinib versus first generation TKI is 31.8 months. So there is meaningful and clinically and statistically significant improvement in the OS with osimertinib. Next slide. So PFS benefit is there, response rates are there, and duration of response is there, OS is there. What about adverse event? Because we are saying that this drug can be given in adjuvant setting, in metastatic setting, both. So side effect profile should be manageable and reversible and early grades, and that is the case. Most of the time, side effects are well manageable and reversible and grade 1 or 2, including diarrhea, skin rash, and pyronychia and all. Next slide. So this study summary, investigator have concluded that osimertinib resulted in highly statistically significant and clinically meaningful improvement in the PFS, significant and clinically improvement in the CNS PFS also. OS benefit is also there with p-value is significant and safety profile is comparable. So with this trial, and they have told that, and it has been stated in clinical setting also, that this drug should be the standard of care for the first line therapy in patients with EGFR mutation positive with advanced NSCLC. Next slide.
तो अगर वो उनका सेटल हो जाए
So as in this slide, I've shown you some regarding some CNS PFS. So just few slides regarding CNS efficacy of the osimertinib, because we all know that these patients, either upfront or during the course of the treatment, they usually develop CNS mets, and that may be symptomatic clinically. So if we can give some drug which is having good CNS penetrability and which can inhibit and which can delay CNS progression, that is the CNS PFS, and this drug have shown statistically significant benefit in that scenario also. Next slide. We can see in these plots. So drug is working even if CNS mets were there or not at the presentation. Next slide. So if we see CNS PFS with osimertinib is not reached versus with standard of care first line drug, it is 13.9 months. Hazard ratio is 0.48 with median follow-up of around 12 months with osimertinib, 7 months with first generation TKI. Next slide. So obviously there are some debate whether we should start with second generation TKI like dacometinib and we can switch over to third generation TKI on progression. So regarding that, next slide. So if we compare PFS with dacometinib, it is 14.7 months, while with gefitinib it is 9.2 months in Archer study. With Fluoride study, it is way better. It is 18.9 with osimertinib, with gefitinib around same 10 months. So there is clear-cut extra benefit of PFS if we give third generation TKI. Next slide. And this benefit is from the very beginning. In Archer study, both the lines are like remaining to separate from each other after 6 months, but that is not the case in the Flora study. Another point is that OS was not statistically significant in the Archer study, although trial design was like that, but still they have not given any statistically significant benefit in the OS. Next slide. While Flora is the first study in which statistically significant benefit in the OS have been achieved with osimertinib. Next slide. Next slide. So this benefit in OS with osimertinib has been seen in each and every subgroups. Next slide. Next slide. Similarly, if we compare osimertinib with afatinib, so next slide. In Lux Lung 7 study, PFS of afatinib is 11 months. If we compare with the first generation TKI, that is 10.9 months. So almost similar. Both the lines are well crossing each other. So even with afatinib, even PFS benefit is not there. So although on the other hand, osimertinib has median PFS of 18.9 months, and so there were insufficient events to determine OS of afatinib at the time of analysis. Next slide. So and OS benefit also not there, PFS benefit also not there with the afatinib. Next slide. Regarding safety profile, so these side effect, mainly EGFR associated side effect, is also very less, almost negligible in with osimertinib if we compare with the other drugs. Most side effect are with the dacometinib. Next slide. So FLORA study was also a sequencing study. Osimertinib have been started as a first line, and then in the another study in which first line first generation TKI and on progression third generation EGF is osimertinib have been given. Next slide. But problem is that not every patient will receive second line because of the deterioration of PS and inability to take repeat biopsy and T790 mutation, false negative results. All these factors contribute around 30% patient only on progression will receive osimertinib. 70% patients will be devoid of the benefit of this drug. Next slide. Hence, the important to start with a drug with a greater benefit compared to the other TKI to decrease this conflict and this problem. Next slide. Because if we use osimertinib as second line treatment, there is benefit, no doubt about that. But what about those patients who may have taken benefit of this drug but will not be given this drug in the first line? Next slide. Coming to FLORA-2, it is a phase 3 trial of first-line osimertinib plus platinum-based chemotherapy in EGFR mutated advanced NSCLC patient. Next slide. In which osimertinib not as a single agent but with chemotherapy have been tried. So for few cycle with chemotherapy, after that single agent osimertinib with pemetrexed and versus osimertinib alone. Next slide. This is the baseline characteristic of these patients. Next slide. So regarding PFS and OS, mainly PFS benefit and CNS PFS benefit. So there is obviously benefit in the PFS and CNS PFS if we give chemo with osimertinib, but with extra toxicities. So in a very fit patient, if disease burden is high, we may go for this approach, keeping into mind that then toxicity may be more and patient should be more PS wise okay to give both the combination. Next slide. So primary result of FLORA phase 3 FLORA-2 trial show that combined treatment of osimertinib and platinum-based therapy significantly improved PFS if we compare with the osimertinib alone. But because if this PFS is 25 months versus 16 months, PFS benefit have been seen in all subgroups. But safety profile of each regime was as expected manageable, although, but we're eager to conclude that this combination is a new treatment option in a newly diagnosed patient, if especially if the disease burden is high. Next slide. But still, at present, we can see single agent osimertinib is the preferred category 1 regime drug for these advanced NSCLC patients if EGFR mutation is there. Next slide. So for the first time in the evolution of EGFR TKI, osimertinib have translated PFS to a significant OS benefit. This drug has median PFS of 18.9 months and median OS of 38.6 months, which is significantly higher with the first and second generation TKI. This drug has shown efficacy in patients with CNS mets also. Fewer and less severe adverse events have been noted and new standard of care for the first line therapy in EGFR mutation advanced NSCLC patients. Next slide. So with this, thank you. House is open for any query you can ask or comment. Otherwise, over to organizer.
Thank you so much, sir, for that wonderful presentation. So our next session is on overview of lung cancer, and I will invite Dr. Pankaj Goyal, sir, Senior Consultant, Rajiv Gandhi Cancer Hospital, to take this topic. Sir, over to you.
Yeah. Thank you, Manish, for having me here. Can you share slides on my behalf, Sarangi? Please share slides.
Sarangi? Sir, wait for a moment. I will call her.
Sir, we are sharing. Just give me a minute or two. Sarangi is sharing. Sir. So Rangi, your looks like your, this. I think you have a poor network. Can you reshare, please? Pankaj, sir, just give us 1 or 2 minutes, sir.
Hello.
Yeah.
Yes, sir. Are the slides visible?
Not yet, sir. Rangi. Yeah, now they are visible.
Okay.
Make it full screen, ma'am.
Yeah. Thanks a lot to all. I'll be talking overview of lung cancer. Can you make it full screen? Yeah. Next slide. Next slide. Yeah, so we know that this is one of the most common cancers in male. Just like we have breast in female, in men, we have oral cancers as first and the lung cancer to stand second, with the high number of patients having this as far as incidence and mortality is concerned. Next slide. Next slide. Next slide. Next slide. So these are the changes what we see in AJCC 7th and AJCC 8, where we see this stage 3A and 2B has been re-inclined depending because of whatever prognosis these tumors have. Next slide. So there are various investigations: bronchoscopy, CT chest, PET scan, EBUS, mid-endoscopy, MRI brain, which when we usually ask for investigations as far as imaging and the diagnostic investigations are concerned in patients with lung cancer. Next slide. Next slide. So lymph node, if they are more than 10 mm, then they are predictor of cancer. And if they are central tumors, depending on the size of tumor, that is more than 2 centimeter or more than 4 centimeter, the chances of having a positivity in that tumor increases. And also high SUV on PET scan also is an indirect indicator that it could be positive. Next slide. So occult metastases are common. So we should be inclined to investigate this patient with either a US EBUS or invasive media cystoscopy, depending upon the stations, whatever are suspected to be positive. Next slide. So these are the various lymph node stations. Depending upon N2 or N3, we have to see whether the patient is a candidate for mid-endoscopy. And according to, we have to plan our treatment in these patients. Next slide. So centrally located tumors, high probability tumor size more than 3 centimeter, again lymph node positivity is high. Bulky N2 or CT, then we take them as obvious positive. We do not need an invasive confirmation. Discrete N2, then we have to see and evaluate them pathologically regardless of the PET scan status. Next slide. So this is the flow. Either we have to do a mid-endoscopy, mediastinal lymph node negative, then we might need to see whether it's node positive, suspicion, then tissue confirmation with EBUS and EUS. It could be a mediastinal positive patient or mediastinal negative. And depending upon that, we have to decide whether the patient goes for surgery or a radical radiotherapy. And similarly, if the patient is lymph node positive, then we have to see whether they are bulky or non-bulky, and accordingly, we have to discuss in tumor board. Next slide. So these are the various stations and the positive yield of various investigation modalities. And according to the station under suspicion, we have to choose the modality. Next slide. Next slide. So sensitivity of individual investigation may be 55 to 60%. But if we combine two modalities, then it can rise to even 80 to 85%. And this was considered as a single disease until we had different subtypes. Now, depending upon the type of adenosquamous or small cell carcinoma and the molecular subtypes, we have various pathologies which we deal with, along with the various molecular testing available with us, like EGFR, MET, L-cross. Next slide. So the lung cancer treatment mortality depends on the lymph node positivity and the molecular subtypes, which we will see in the subsequent slides. And the mortality has decreased, survival has improved because of the various investigation modalities and the treatments. Next slide. Next slide. So a significant increase in approvals of various targeted agents have been seen in past 2 decades. And we have various mutations like EGFR, L, CROSS, RAF, and NTRK, MET, RET, which can be targeted with these treatments. Next slide. So if patient is having a stage 1A, then usually it's observation. Apart from that, if it is 1B or 2, then we have to discuss in the multidisciplinary board. 2B onwards, adjuvant chemotherapy is required, and now focus has been there on neoadjuvant chemoimmunotherapy in the advanced stage lung cancers. Next slide. Next slide. Next slide. So after surgery, 40 to 50% of the patients will remain cancer free, and 50 to 60% of the patients have recurrence, especially so the local, the distant recurrence. Next slide. Next slide. So pooled analysis of 5 trials evaluated adjuvant cisplatin-based chemotherapy, and it has shown to have a overall survival benefit. Next slide. So for stage 1B to 2A, neoadjuvant chemotherapy is indicated, and hazard ratio is 0.87 for the same, as has been seen in the various trials and the to combine analysis. Next slide. Next slide. So improved DFS is seen with osimertinib, wherever it's indicated in the metastatic setting, and adjuvant in the patients who are EGFR mutant. And Adezo showed an improvement in survival in adjuvant setting in the patients who had a PD-L1 status more than 1% who are wild types. Next slide. So IMRT has improved the outcomes and decreased the side effect in the patients who are having T3, T4 tumors, where it's indicated along with the N2 status. Next slide. Next slide. Next slide. So pulmonology is important, and between various radiations is where creating a new radiation plan sparing, which result to lesser side effects. Next slide. So long-term results we have seen it with the radiation, and there is no benefit of RT dose escalation or cetuximab. There is a 10% overall survival benefit with the radiation. Next slide. So this is again the summary of all what we have discussed. For patient stage 3, medical oncologists should work closely with radiation oncologists to ensure a coherent approach. Not all patients will complete their prescribed course of chemotherapy when we use them sequentially. Next slide. So unresectable stage 3, again we see as per the Pacific trial is concerned, that in the patients who have received a consolidation with the immunotherapy improves the benefit in these patients. Next slide. So Pacific trial, we saw that durvalumab demonstrated 42.9% OS at 5 years. So there was a significant survival benefit with usage of adjuvant durvalumab. Next slide. Next slide. So Flora trial, we saw the first line osimertinib, first generation TKI, where we saw that the PFS improved drastically, 18.9 months as compared to 10.2 months. And Alex trial, the PFS with first line elective improved it further to 34.8% as compared to 10.9 months. Next slide. Next slide. So we have different drugs available for these rearrangements like ret rearrangement. We have cabozantinib or bendatinib, which is 1 to 2%, NTRK 1%, larotrectinib and entrectinib. For HER2 mutant patients, we have adagrasib, and for MET, crizotinib, which is 3 to 5%. Next slide. With recent advances, we see the compared to chemotherapy alone. So, way with chemotherapy, it's only 1 year. These newer target agents cross even 3 years in many patients. Next slides. Next slide. This is the mode of action of immune checkpoint inhibitors. So these use the body immune system to fight these cancer cells with PD and PD-L1 blockade. And this, we have this capemalimab, which has approved in 2021. Combination of nivolumab and ipilimumab for patients who are more than PD-L1 more than 1%. Next slide. Next slide. Next slide. So we have these various approvals of immunotherapy based on the histology and PD-L1 positivity. And in stage 4 NSCLC, we see that it has improved the overall survival wherever it's indicated using pembrolizumab versus just chemotherapy in the patients who are having PD-L1 more than 50%. Next slide. Next slide. Next slide. So multiple ongoing trials are there for pembrolizumab, durvalumab in adjuvant, new adjuvant studies, which we will see in further years to come. Next slide. Next slide. So with these ADCs and CAR T cell therapy, we expect we'll have further better results. ADC like this, we are having this HER2, which are being used. And also the CAR T cell therapies are having phase 1 data at present, but in the coming years, probably we'll have many more results with the CAR T cell therapy as well. Next slide. So the management landscape is fast changing in NSCLC. Newer therapies have a huge potential to improve survival, especially if detected in early stage. The OS is improved across various subtypes. The ease of oral pills over infusion in case of target drugs is added advantage. Pulmonologists will play a huge role in early diagnosis. Hence, it's crucial to have a NSCLC tumor boards. With that, I'll conclude my session and thanks a lot for patient hearing. Thank you.
Sir, Dr. Pankaj, thank you so much for giving us the overview.
Thank you.
So next topic, I will be taking on genomics of solid. Dr. Abhishek is busy and he will take the next topic. Can you please share these slides?
Sure, sir, I will share.
So this session is sponsored by SNGene, and the topic is genomics in solid tumors.
Are the slides visible, sir?
Yes, please make it full screen. Next slide. So this is a dedicated genomic facility, and they are the pioneers in the genomic testing. The lab is doing all the kind of broad spectrum of testing of solid and liquid malignancies, and they have the international presence, and they are tested by key opinion leaders. Next slide. So once we are doing the genomics of a tumor, we are able to precisely treat the tumor. So this is called as precision medicine. So beyond initial diagnosis of solid tumor, so imaging techniques and tissue pathology analysis. Molecular assays, they are increasingly available, and they provide further solid tumor analysis and characterize the cancer. So molecular assay consists of the analytical test of the measurement of the molecular traits, which are commonly called as cancer biomarker. So these biomarkers, they are of two types. They are either predictive biomarkers or the prognostic biomarkers. Predictive biomarkers are those biomarkers for which we have the drug available with us, and prognostic markers are those biomarkers for which we do not have drug, but they can tell us exactly how the tumor is going to behave, what is the kind of the biology of the tumor, and what would be the PFS or OS of the patient. So the biological biomarkers assay, they are performed directly on the tumor cells or by analyzing DNA or RNA protein that are procured from the tumor biopsies or the liquid biopsies, which is also called as CTCs or circulating tumor cells. So nowadays, the molecular testing is standard strategy for all the solid tumors for classifying the solid tumors. Next slide. So each year there are numerous promising cancer treatment that are being developed and are being approved. And with the advent of the artificial intelligence coming into the play, we can expect that the new drugs would enter the market very, very early. So the timing of the drug development program, which ranged between 15 to 20 years, can now be significantly lessened to even 4 to 5 years with the help of AI and these precision genomics, which is now available. And these therapies often target the specific molecular biomarker that drive the cancer cell. That is why they're called as driver mutation. With the increasing number of the biomarkers, it is essential to find the way out to maximize the ability to match the patient with the appropriate molecular treatment. So earlier on, we used to have very few biomarkers available with us, and now we have n number of biomarkers which are available and n numbers of the drug which are available. So we need to have the high throughput sequencing for our patient, with the help of which even the smallest amount of the DNA or RNA which is available to us, the few cells or the tissue which is available to us, we can make the decision with the help of that sequencing. So while many biomarker tests are available to aid the therapy selection, ordering the individual sequential test, they can be challenging due to the limited amount of the biopsy samples, and the single gene test, they have limited content and may miss the opportunity to identify the positive biomarker, making it important to find efficient and comprehensive ways to identify the biomarker and improve the treatment outcomes. Next slide. So these are various biomarkers which we know of as of date. Many are still evolving. The story starts from very old ER/PR, HER2/neu testing, and then BCR-ABL gene in CML, which we know of for quite a decade. And these are the few biomarkers which we have discovered in the recent years, and the drugs for these biomarkers are available. So it include EGFR, ALK, germline, BRCA1, 2, PIK3, ROS1, NTRK, HRD, PDGFR, BRAF, then MSI, tumor mutation burden, ALK, KRAS, G12C, for which now we have a drug, sotorasib. Other than that, EGFR exon 20, for which we have drug now. Then the RET rearrangements, for we have the drug in January 22. So we have plenty of biomarkers, and these are evolving, and the newer drugs they are coming. So we need to have a comprehensive test which can look out for these either hotspot mutations or a comprehensive genomic analysis, so that maximum number of the patients they are matched to the respective drug which is available. Next slide. So these are the US guidelines which shows the rapid uptake of the genomic testing in various indications. So you can see in 2017 and versus 2022, the number of the cancers which are now being genomically tested and they are approved by the various international authorities for which the biomarkers and the drug is available. So the share of them was very, very low in 2017, which rose significantly in 2022. All of these includes Wilms tumor, thyroid carcinoma, GIST, soft tissue sarcomas, lung cancer, CNS lymphomas, melanomas, head and neck cancer, bone tumors, GI, CUP, and NSCLCs. Next slide. So increasing number of biomarker could have approved the targeted therapy for NSCLC by 2025. So you can see the number of the biomarkers which were available prior to 2021 and now in 2025, how many more biomarkers would now be available for the treatment of our patients, either NSCLC or CUP, the carcinoma of unknown primary. We can do the genomic sequencing for the tumor and then we match the drug to the target which we find in the genomic sequencing. Next slide. And these are the biomarkers likely to have approved targeted therapy in HER2 negative, hormone receptor positive breast cancers, which include HRD, KRAS, BRAF, BRCA, ESR1, NTRK, PIK3, TMB, AKT4, ATM, MMR, PTEN. So all of these, there we are likely to have the therapies for all of them in the breast cancer in 2025. Next slide. Next slide. So genomic profiling has a multiple potential clinical application, including at various stages along the patient journey. Mutations that arise early in the tumor evolution, they can help in the diagnosis. For the treatment selection, we have the option of CGPs, comprehensive genomic profiling. After the treatment, to detect minimal residual disease, we have the option of MRD, which we are frequently doing in the leukemias, myelomas. We have some evidence of MRDs in the colorectal cancer also after surgery. Then in the surveillance setting also, or the response to the neoadjuvant setting, we have different biomarkers like CTCs available with us. Then for the recurrence also, the repeat biopsy and CGP may be done. And on progression, the mechanism of resistance can be found out by monitoring the response to the treatment and doing the CGP in the blood or the solid tumor. Next slide. So this is the hotspot NGS versus comprehensive genomic profiling. Hotspot NGS looks onto the specific mutations which are known, while the comprehensive genomic profiling looks out for the mutations for all those, the hotspot mutations as well, and the other than that, CNVs and the fusions and the splice variants. Next slide. So these are the single gene biomarkers hotspot panel which are available, and the comprehensive panel, single sequencing and FISH probes which are available. So EGFR, KRAS, NRAS, BRAF, KIT, MGMT, PIK3, PDGFR, IDH1, 2, and POL. You can see that those on blue, the NGS is going to help for those in black. The Sanger sequencing is available. So the maximum output is with the help of NGS. We can have the small panels, we can have the large panel. If we are going to look for a single gene, it is either ddPCR or FISH or Sanger. But if we are going to look for the multiple hotspot mutation or the comprehensive panel, then the NGS is going to be the answer for that. Next slide. So this is targeted NGS versus quantitative PCR and Sanger sequencing. There are certain limitations and benefit for the various methods. So for targeted NGS, you have to know that the targeted NGS simultaneously screens the several hundred to thousand of the genes. Benefit is that it is expanded discovery powered through the comprehensive genomic coverage, high analytical sensitivity, greater resolution of the genomic variant. Limitation, it may be less cost effective often, and it requires a dedicated data handling workflow. For Sanger sequencing, the benefit is that it is cost effective for small stretches of DNA, but limitation is that there is low sensitivity, low discovery power, not cost effective for the large stretches of DNA if you want to do a comprehensive genomic sequencing. Hello? Surangi, am I audible?
Yes, sir, you are audible.
So I think
Internet
Surangi,
issue. Wait 1 second, sir.
Surangi has left. Please ask her to rejoin and share the screen.
So I'm sharing the slides again. Sorry for the inconvenience.
Yes.
I think there's some issue with the network. So sorry to keep you waiting, but kindly bear with us. Maybe, yeah, I think she has already shared.
Please make it full screen. Yes, thank you. So the benefit of quantitative PCR is that it allows for the analysis of the particular variant at specific location. It has high sensitivity, quick and simple workflow, capital equipment already found in the most of the lab. Not much of the equipments are needed, but limitation is that only examines the small set of variant, virtually no discovery power, and low variant resolution and low scalability. So overall, if you want to have the greater data, the comprehensive profiling, you want to see 500 or 1,000 genes, then it is not possible with either PCR or either Sanger sequencing. The only answer for that would be the NGS. Next slide. So FISH rapidly identifies the fusion with NGS can be followed up with the FISH for the confirmation or analysis of the variation over time, and use FISH to test for the high probability targets in tandem with NGS to cover the possibility of negative FISH results, and use reflexive testing for more comprehensive analysis. Next slide. So coming on to the solid sequencing CGP and CGP plus assays, which can detect multiple biomarkers in a single assay. Next slide. So these are various options which we have. We have HRD score. It can be combined with the genomic-wide HRD score, also known as genomic sequence signature assay. This has got less failure, optimize workflow to get the results for the low quality FFP tissue complex, TMB MSI, the 550 gene panel targeted capture. The platform used is Illumina high throughput sequencing, NovaSeq 6000, which can give you the 500x higher depth compared to the other platforms. Next slide. So we have the sarcoma expanded NGS panel. This is NGS assisted sarcoma molecular characterization, which can detect the fusions, or one can order for the expanded panel plus comprehensive DNA panel. Next slide. So the sarcomas, they are the complex disease. Although we do not have the targeted treatment available for sarcomas, except for the liposarcoma or a few of the other for which the drug is available in the clinic, like palbociclib, a CDK4/6 inhibitor. But the various studies have shown that the sarcomas, they can have complex multiple mutation, and sometimes these mutations can be the driver mutation. So well differentiate liposarcomas, they have CDK4/6 as a molecular target. Then MDM2 is the another target for them. Epithelioid carcinoma and synovial sarcomas, they have AZH2, which is the methylation sensing of the DNA. And for that, the targeted treatment available is tazemetostat. Then TRK fusions can be found in multiple sarcomas in the children, for which we have the drug larotrectinib. Then the various other studies have shown various other kind of alterations in the sarcomas, for which presently the drugs, they are not available, but at least fewer sarcomas, they can have these alteration, and these should be tested for the targeted treatment in the advanced stages once the surgery, radiation, and chemotherapy has exhausted. Next slide. Next slide. So coming on to the genomic signature, homologous recombinant deficiency score, that is HRD score. This is the predictive biomarker to target for the targeted therapy for the PARP inhibitor like rucaparib and olaparib. The assessment of genomic instability is done with the help of 3 biomarkers, which is loss of heterozygosity, telomeric allelic imbalance, and the large scale transition, that is LST. Next slide. So most of the causes of the homologous recombinance deficiency, they are unknown, but the promoter hypermethylation, BRCA mutation, 1 and 2 mutation, HRR pathways, they contribute to HRD, and few of the causes, they are unknown. These all lead to the instability in the DNA, inability to repair the DNA, leading to the genomic instability. And these patients, they respond beautifully to the PARP inhibitors. Next slide. So you can see with the help of the HRD, we can identify 52% patients for the PARP inhibitors. But if we just test HRR pathway genes, the results drop to 30%. If we just test for BRCA1 or 2 in the somatic tissues, the results drop to 20%. But if we just test for germline mutation, the only 12% patient, they are eligible for the PARP inhibitor. So the recommendation is to do the HRD testing for all the patients of the ovarian cancer, stage 3 or more, for which we are anticipating the PARP inhibitor treatment. Next slide. So these are various FDA approved PARP inhibitors, we have already discussed. Next slide. So 154 gene NGS panel, comprehensive hereditary cancer panel assays are also available to detect the hereditary nature of the disease. Next slide. Then liquid-seq, the comprehensive liquid biopsy assays, targeted therapies, and for the monitoring, it is also available. Non-invasive, easy, quick, and cost-effective variant detection down to 0.1% from the targeted NGS assays. Next slide. So as we already said in the previous slide, these NGS assays, they can help for screening. It can help for detection of MRD post-surgery. It can help in detection of the relapse, early relapse, and it can help in the detection of the resistant mechanism for the tumors after chemotherapy or the targeted therapy. So it enhances the understanding of the tumorigenesis, metastasis, therapy, and resistance. It can help for monitoring of the cancer development, disease progression, and recurrence, detection of the cancer at the early stages when the treatment may be more successful, and tracking the response or the resistance during the treatment. Next slide. So these are various liquid-seq panels which are available. EGFR hotspot panel by ddPCR detecting L858R, T790M, and exon 90 deletions. Lung cancer panel, NGS-based 12-gene hotspot panel. Pan cancer panel, NGS-based 52 gene hotspot panel. Advanced breast cancer panel, 93 genes. Comprehensive liquid-seq 275 gene panel. And then CGP liquid-seq, which can detect 550 gene in the blood or in the blood. Next slide. Thank you so much for your patient listening. If there are any questions, we can take a few questions. Okay, I think Dr. Abhishek is here. Dr. Abhishek.
Hi, good evening, Dr. Manish.
Good evening, Dr. Abhishek. The
I hope
next,
I'm audible.
sorry.
I hope I am audible.
Yes, you are audible. So the next talk is by Dr. Abhishek. He will be talking on the genetics of the NSCLC. What are the targeted treatment which are available, and what are the various tests which are available for these patients. He is a senior consultant at Yashoda Medicity, Delhi. So I invite Dr. Abhishek. The stage is yours.
Thank you, Dr. Manish, for this opportunity. And the topic that I'll be taking up today is the molecular testing and molecular biomarkers in non-small cell lung cancer. Can somebody share the slides from my side, please?
Sure, sir. Are the slides visible, sir?
Yeah, thank you. So next slide. So what we'll be discussing is the lung cancer status in India, biomarker testing, evolution of the biomarker testing, and the key takeaways. Next slide. So the burden of cancer, lung cancer in India, this is the Globocan 2020 data. Next slide. So lung forms almost if we take in the both the sexes, that is the male and female, it forms around 72,000 new cases every year. And if we see in males, then after lip and oral cavity, it forms the second most common cancer amongst males in India. That is around 40,000 new cases every year. Next slide. Next slide. Next slide. So 50% patients with advanced non-squamous NSCLC have a driver mutation. targetable with an FDA approved agent or on a clinical trial. So we can see that the most common mutations that we see in NSCLC are the KRAS mutations, which is around 25%, and followed by the EGFR sensitizing mutations, which form the 17%, followed by the ALK mutation, which forms 7%, and then we have MET mutation, mutation, the HER2/neu mutation, ROS1, BRAF, RET, NTRK, PIK3CA, and MEK. And we have some unknown oncogenic driver in almost 31% of patients. And for KRAS, EGFR sensitizing ALK and MET exon 14 and HER2/neu and ROS, BRAF, RET, and NTRK, we have targeted therapies or tyrosine kinase inhibitors available. Next slide. So it is very important to test biomarkers in non-small cell lung cancer. So whenever you come across an non-small cell lung cancer, even if it is a squamous patient is non-smoker, a female, or patient has left smoking quite a years back, or was a light smoker, then we have to at least test for the EGFR, ALK, and ROS. So studies have shown that patients with identified actionable mutations who receive appropriate targeted therapy have improved outcomes. So this is the survival probability over the time, that is in months. We see that the patients who received targeted therapy, they fared well right from the beginning. And for a follow-up of around 50 months, they fared better than the patients who received no targeted therapy based on the biomarker testing. Next slide. So there are various guidelines like ESCO, NCC, and ESMO and CAP. So all guidelines recommend routine biomarker testing to guide treatments in advanced NSCLC. We see that in EGFR mutations, all of four of them recommend the testing as same as for ALK and ROS. For BRAF, except for CAP, they all recommend. MET exon, RET, and NTRK, KRAS, and PDL1 expression are all recommended by the NCCN guidelines and the ESMO guidelines. So we all know that these are the most two common guidelines that we follow in our clinical practice. Next slide. Next slide. So the methods of tissue testing in NSCLC. So you can do a DNA sequencing, a next generation sequencing. Previous slide, please. So they detect insertions, point mutations, deletions, and aberrations. Single gene or full gene NGS panels can be done. Then there are RNA sequencing panels, which are most commonly used for fusion abnormalities, more sensitive for ALK, ROS, TET, and NTRK fusions. Then there is IHC and FISH. The FISH detects ALK, ROS, highly specialized, can be faster. IHC again detects ALK, ROS, easy test, less costly, but not reliable or sensitive enough to guide treatment. But then we know that ALK D5F3 is very commonly accepted as the treatment guideline. If it is positive, then we can start the ALK TKI. Next slide. So we see the evolution of biomarker tests in NSCLC. Next slide. So this is how this shows the journey of the small biopsy that we do from the procedure of doing a biopsy to the analysis. So we can do an excision biopsy, we can do a resection, we can do a core needle biopsy, we can do a fine needle aspiration, we can do an exfoliative cytology, then we can do liquid biopsies if the biopsy is very risky or the patient is not ready for that invasive thing. And followed by fresh formalin block, then followed by histology, cytology. Parallelly, we get the IHC done for PDL1, DDM for MSI for PDL1. Then we get the DNA sequencing, RNA sequencing, or the proteomics for the further biomarker testing. Next slide. So biopsy establishes the diagnosis, determines the histological type, and also gives us the tissue for the biomarker testing. So if the tissue is not sufficient and the rebiopsy is not possible or the rebiopsy is very difficult, liquid biopsies are another option which are coming up very fast. And we test for PD-L1 expression in all NSCLCs is the target. Next slide. So circulating tumor DNA testing has the potential to be applied across all stages of NSCLC and throughout the treatment pathway. So as I already said, this is coming up in a big way. So for diagnosis and treatment selection, for monitoring prognosis, from response to treatment and progression or relapse of disease, to some major challenges associated with tissue testing, like I told you that serial biopsies are needed. Patient is not willing for it, or it is the biopsy is very risky. And ctDNA in the bloodstream is comprised of DNA from the all tumor sources in the body. So captures both tumor heterogeneity and tumor changes over the time. So this is very important. So ctDNA testing may never replace tissue biopsy entirely, but could have a complementary role to support the treatment selection in patients with NSCLC. Next slide. Next slide. Next slide. Next slide. Next slide. Next slide. Previous slide, please. So circulating tumor DNA will be used to detect MRD, that is the minimal residual disease after surgery in restricted NSCLC. So probably this will tell us. So this was a very small study done over in the 24 early stage NSCLC patients followed longitudinally after resections, and it was seen that the patients who had MRD positivity with the circulating tumor DNA were more likely to relapse. That is 93% patients relapsed, and 90% of the patients without recurrence were MRD negative. So this is something I think will come up in a big way to determine whom to give adjuvant chemo, whom to keep under the very close surveillance and very close follow-up. So this is something which I think will be tested more in the upcoming studies and upcoming trials, and this can be really a very guiding, really the guiding torch for a medical oncologist to for follow-up and further treatment. Next slide. So comparison of tissue versus liquid biopsy testing, we all know that for the tumor tissue, obviously obtains the more DNA, the more tissue, but then it is more, it is invasive, it causes pain, it causes the more the procedure in itself is costly, and the liquid biopsy, the simple blood draw is enough. That is, we just need a 10 ml blood. It is minimally invasive. Uh, the demerit is that direct correlation between ctDNA results with the histology of cell type is not possible. So very sensitive methods are required, as ctDNA may comprise of less than 0.0% of the DNA. So standards are still not as well established as that of the tumor tissue biopsy. There is less, but then the incidence is increasing for initial targeted treatment selection and subsequent treatment after targeted treatment failure in the advanced NSCLC. Next slide. Next slide. Next slide. So there are multiple genes involved in NSCLC, single gene reflex testing or multiple gene reflex testing by NGS. So this forms the dilemma whether to test the individual genes initially or directly go for the next generation sequencing. So if we go for a single gene testing, then we get early results, but then it is not possible to, it burns out the tissue. So we have a very limited tissue available. So it is for, if we keep on testing for the single biomarker, then the tissue probably gets insufficient, and ultimate cost might increase if we don't find a mutation in the commonly encountered genes. So NGS then again is in one go tests all the genes, but then it is time taking. Next slide. Next slide. Next slide. So NGS has a number of advantages. That is cost. The cost is more effective for an NGS rather than testing for the individual biomarkers, but then the turnaround time is larger. it takes more time than the individual gene testing. So if many molecular markers are needed, it reduces the cost, shorter turnaround time, and lower tissue requirement versus single gene. So pros of using NGS are detects a broad range of molecular alterations. Especially we know that in exon 20 insertion mutations, it is NGS which identifies most of the mutations rather than a PCR. So we may identify new markers that could offer additional treatment options for patient. So cons of using an NGS are high complexity of workflow that requires experienced personnel and experienced database. Advanced in the field of NGS are evolving rapidly. Patients and the clinical community must receive sufficient education in this area. Next slide. So techniques and molecular landscape in assays, there are single gene assays, single sequencing, pyrosequencing, allele specific PCR, single base extension, multiplex ligation dependent probe amplification, mass spectrometry, gene panel assays, amplicon-based panels, hybrid capture sequencing, next generation sequencing, fluorescence-based methods like FISH, and microarray-based CGH. Next slide. Next slide. So we see the EGFR mutation in lung adenocarcinoma. Next slide. So FFP sections, fresh, frozen, or alcohol-free specimens can be used for PCR testing. Cytology samples are also suitable. Cell blocks are preferred over smears. So discordance between EGFR mutation status in primary tumors and corresponding metastases are rare. Next slide. So EGFR mutation testing in early lung cancer, when to do it? Next slide. So NCCN says that consider adding molecular testing for EGFR mutation to perform on diagnostic biopsy or post-surgical resection sample to ensure the EGFR mutation results are available for adjuvant treatment decisions for patients with 1B to stage 3A NSCLC. As we know that osimertinib is recommended for adjuvant treatment of NSCLC from 1B to 3A stage post-surgery. Next slide. So as we have already discussed that the big advantage of NGS over PCR is the detection of EGFR exon 20 insertion mutations. Next slide. So now we see the L3 alignments. Next slide. So false positivity rate with FISH is only 0.1%. So this is an advantage over IHC. IHC is very sensitive, but then FISH is very, very specific. So IHC is less expensive, hence the D5F3 is more widely adopted. Next slide. So ROS1 rearrangement in SCLC. Next slide. So algorithm for predictive genetic testing in advanced NSCLC. So we see the routine practice. So if we come across a patient, we test the EGFR, ROS and ELK, individual testing, and ROS is tested by IHC, ROS can be tested by FISH. If ROS is positive by IHC, reconfirmation by a second method is ideally done. And if ROS is positive by FISH, then also a reconsideration of by testing by IHC can be done. Next slide. So KRAS mutations are mutually exclusive with EGFR and mutation. So if you find a KRAS mutation, very, very unlikely that we will encounter an EGFR or ALK mutation. So most common of these arise in codons 12 and 13. And the method of detection is a multi-gene NGS panel. So targeted therapy like sotorasib and adagrasib are available. And acquired resistance to therapy has been observed, although specific resistance mechanisms are not well understood. Next slide. We come to the BRAF mutations. More than 50% of BRAF mutation cases are actually BRAF V600E mutations, more prevalent in smokers. Non-V600E mutations such as V600K, G466V, and G469A are also less prevalent and form around 17% of the BRAF mutations. So overall, BRAF mutations occur with a frequency of 1 to 5% of NSCLC cases. NGS is again the preferred method. The targeted therapy available is dabrafenib and trametinib. Next slide. So if we see the c-MET receptor tyrosine kinase and MET exon 14 skipping mutations in SCLC, majority of MET exon 14 skipping mutations can be detected with DNA NGS. But if we go for an RNA NGS, it is even better. Next slide. So for MET exon 14 mutation detection, IHC is not recommended, FISH is not recommended, PCR can be done, but then the preferred method is NGS, RNA more than the DNA. Next slide. We come to the red tyrosine receptor tyrosine kinase and TRET fusions in SCLC. We see that this gene is important in the neural genitourinary development. So majority of red fusions can be detected by DNA NGS, but again, just like the MET, the RNA NGS is the preferred method to detect the mutations. Next slide. Next slide. Testing for NTRK, again, the RNA NGS is more sensitive in comparison to the other methods. So reflexing to NGS with ISC versus ISC is reasonable for NSCLC due to low prevalence of NTRK fusions. Next slide. So what are the methods? So NGS is the preferred method. FISH gives the rapid results. ISC also gives the rapid results, but is has low cost. But the advantage of NGS is that it makes the multiplex testing possible, less depletion of tissue, fusion partner more sensitive than the DNA NGS. Next slide. Now to HER2 mutations, so around 3 to 5% of sensitive customers have HER2 mutations present. So mostly are exon 20 in frame insertions, mutually exclusive with other mutations, worse overall survival than other subtypes of lung cancer mutation consortium. So in NSCLC, HER2 mutation and amplification must be identified using a DNA NGS panel similar to breast cancer. So IHC used to assess HER2 new overexpression seen in 59% of NSCLC cases. Next slide. So this is the 2022 treatment paradigm for molecular biomarker positive advanced NSCLC. We know that if for classical DEL19 or IL-858R, we have osimertinib. Then we have others. This is the preferred class. Then others like alortinib, afatinib, treftinib, or decomitinib. We have then uncommon exon 20 insertions for which we have the bispecific antibody like amivantamab, brigatinib, and dolatinib. Then for ROS, we have quizartinib or entrectinib. For BRAF V600, dabrafenib, tremetinib, NTRK, entrectinib or darotractinib. RED for selpercatinib or praseltinib. For metexon 14 skipping mutation, capmatinib or tepotinib. And for KRAS G12C, we have sotorasib. Next slide. Next slide, please. We see the now we come to the PD-L1 overexpression. Next slide. So we have different antibody clone, the platforms, and the platforms are the antibody clones are 22C3, the SP263, SP142, and 28-8. So the platform is DACO Ventana. So diagnostic type is companion complementary. So 22C3 DACO is companion. SP263 is for durvalumab, done on the Ventana platform. It is complementary. And for SP142 is for atezolizumab, again Ventana platform, complementary. And for nivolumab, it is DACO 28-8 and complementary. So scoring systems are different. Next slide. These are the various antibody clones which detects the PD-L1 testing. So different antibodies are used. A different scoring system is adopted depending on the antibody used. Next slide. Next slide. So biomarkers for immunotherapy in SCLC. Previous slide, please. So biomarkers for immunotherapy in SCLC is a controversial topic. So PD-L1 sole current biomarker able to guide immunotherapy. Imperfect. We all know that. PD-L1 negative tumors can still respond, albeit mostly when added to chemotherapy. We don't know whether this is a synergistic effect. So tumor mutation burden, formal marker for response, not currently used. Conflicting correlation with survival in the various checkmate studies. So MSI high, not used or relevant in lung cancer. So LAG3 possibly related to resistance to immunotherapy being studied, still being studied. Next slide. So to conclude, biomarker testing in SCLC evolved from single gene to multiplex testing. Multidisciplinary meetings help in better understanding of sample and test requirements. Sample should contain adequate tumor content, at least 10% to prevent delay in processing. So ideal time is 2 weeks, that is 10 working days. High throughput platforms such as NGS can be used to screen several genes at a time to provide results within the estimated time. Thank you so much.
Thank you, Dr. Abhishek, for taking us through the genomics of lung cancer. So if anyone has any question, we can take few questions. So if we do not have any questions, then we can thank the attendees and colleagues for taking their time. Good night to all. Thank you so much for joining us.
Thank you so much, everyone, for joining today's webinar. We'll see you again. Good night.
Could you
Technical
close the
team,
session?
please close the. Yeah. Thank you so much.
Okay, thank you.